Started off by saying that I will put forward a disclaimer. I am employed by the World Health Organization or the Pan American Health Organization, and my views are personal and professional. They may not necessarily represent those of PAHO WHO, and as a former Premier and Minister of Health and former CMO of the TCI, but my views are apolitical and do not represent that of any government or political party. With that said, let us go into the area of COVID-19. I don't know how many of you would have read the book, The Art of War. If you're in a war and not feel you win that war, a few things you must recognize. If you know not yourself, know your enemies. You will always endanger yourself and lose the war. If you know not yourself, if you know yourself but not your enemy, you may win or you may lose. If you know yourself and your enemies, you will put yourself at risk. You will not put yourself at risk even in 100 battles. And this holds true for persons in real war, in business, as well as in medicine in the case of COVID-19. So knowing yourself and your enemies allows you, and I will include you as being individuals, business, and country, to proactively prepare to defend against and defeat your enemy. So let us get to know our enemy. Our enemy is a virus called the SARS-CoV-2 virus. It belongs to a family of coronaviruses. This family of coronaviruses are not new to us because they have caused several pandemics, or not pandemics, but epidemics in the past, including MERS, as well as SARS. SARS, which is acute severe respiratory syndrome, outbreak in 2002, and the MERS, which is the Middle East Respiratory Syndrome in 2019. Now, this virus is new to this family. It is also new to humans, and it's new to the family of coronaviruses. The genetic material of the RNA suggests that it originated in bats and transferred to humans through an unknown intermediary animal host. Now, this is the most popular theory to date. Now, the virus consists of an RNA core. This RNA, this genetic material, is essential for the virus to be able to replicate within our human cells, as well as a lipid envelope. And this lipid envelope protects this RNA core, and it has some proteins on it that allow this virus to attach effectively to the cells to enable it to invade the cells. The mode of transmission or attack of this virus are two main modes of transmission. There are viral particles that are suspended in what we call respiratory droplets. These viral particles can come into contact with mucous membranes of the eyes, the nose, or the mouth. The viral particles are also found in stool samples, in a few stool samples in some studies. And the infection occurs via either inhalation of these droplets. These droplets can be of varying sizes, could be of the large size, or the very small micro droplets or aerosolized droplets. The infection could also occur when you have direct contact with the virus on your hands, and is then transferred to the eyes, the nose, and the mouth. The virus is not airborne. In some studies, it has shown that the duration that it lasts within the air depends on the size of the micro droplets. So we found that in situations where the virus is aerosolized or converted into mist-like micro droplets, you may find that they last in the air a bit longer than those droplets that are larger after you cough or sneeze that falls to the ground within 3 to 6 feet. And that is why we have established the so-called minimum distance of 6 feet or 2 meters as part of our social or physical distancing. The virus is very efficient in terms of it attaches to a receptor called the ACE inhibitor or the ACE receptors. That's acetylcholine receptors, which are present in the respiratory cells. These are within our respiratory tract. And upon attaching to these receptors, it then can enter the cell and multiply. Now, the risk of transmission, however, of the virus is very high or higher in persons who are symptomatic, but studies have also shown that there are also high rates of transmission from asymptomatic or pre-symptomatic persons. This transmission enables us to have what you call the attack rate, which is the number of persons, and this is referred to as R0, which is 1.5 to 3.5, which means that for every one person infected, that person is capable of infecting 2 to 3 other persons. Now, the SARS or the COVID virus has a greater transmissibility than its other family members, such as SARS and MERS, but these latter two are more pathogenic, meaning that they're more lethal. They cause severe disease and deaths. So while you may have COVID having a case fatality of around 2%, so about 2% of persons who are infected with COVID will die, we found that in the cases of MERS and SARS, from 10 to 30% of those individuals will die once they contract the virus. But the difference between those viruses and what we have now with COVID is that those viruses, the transmissibility is much lower. And so the spread of those viruses was not as extensive as that of COVID. And because they're not as extensive, then the deaths that occurred during 2002 and 2012 outbreaks were not as high as we are experiencing now with COVID-19. Now, the clinical features. So upon invasion of the body, the signs of invasion that we can detect stems from the moment persons is infected to the minute they start developing symptoms. It takes about 2 to 14 days before symptoms develop. These symptoms could range from a variety of severity, but this period from 2 to 14 days is what we call incubation period. In some cases, individuals will never develop symptoms, and those individuals are referred to as being asymptomatic. So even though they have the infection, are infected with the virus, they never develop symptoms, and they are called asymptomatic. But those who develop symptoms, the symptoms may range from fever, dry cough or fatigue, shortness of breath, myalgia, confusion and headaches, and loss of taste and smell. And those are the more common symptoms that persons will experience. But we have also atypical symptoms because the virus also is present within our gastrointestinal tract. We may have other atypical symptoms such as diarrhea and nausea. The disease, however, may progress from being a mild form of the disease to severe forms of the disease with progressive shortness of breath and development of pneumonia, development of renal failure, having cardiac injury, and eventual death without any kind of medical management, or even in the best of hands with medical management. Now, the majority of the cases, however, of COVID-19, 80% of them are mild, and the majority of individuals recover without any kind of intervention. And when we say recover, we don't only mean recover clinically, meaning that they no longer have signs and symptoms, but also recover to the point that the virus itself no longer exists or present within the body. Now, we all know that the origin of the virus started with the first reported case in Wuhan, China, on December 31st, where there were a cluster of cases of 27 cases. And with this cluster of 27 cases, The disease then progressed and spread to other regions of the globe. So on January 30th, a public health emergency of international concern was declared by the World Health Organization. Now, this declaration of the public health emergency of international concern, what it did was allow for not only the mobilization of resources in collaboration between countries, but it mandated the reporting of COVID cases to the World Health Organization through the international health regulations mechanism. So member states of the World Health Organization were mandated to report these cases to the World Health Organization. This facilitated collaboration also between countries so that persons could know which countries have high levels of the disease, as well as which countries are at risk based on trade and travel issues. The first case appeared in the United States on January 20th. And by March 10th, the first case was reported by a CARICOM member state. On March 11th, COVID-19 was declared a pandemic. And pandemic simply means that several countries around the globe and several regions of the globe would have been impacted or affected. And this declaration did not add any additional value in terms of the strategies with regards to how we're dealing with the disease, but it facilitated, it made that declaration to give that recognition and to allow certain things to happen between countries. Now, at that time of the declaration of the pandemic, about 114 countries were affected and 4,291 deaths had already occurred. In looking at the rate of spread of the epidemic spread exponentially across the globe, where we now to date experiencing about 2.4 million cases globally, with over 160,000 deaths also reported globally. We in the Caribbean region, when you look at the region of the Americas, which includes North America, Central, South America, and the Caribbean region, we have 858,631 confirmed cases with a total of 40,000 plus deaths. But out of that, 7,176 COVID cases within the Caribbean region, ranging from as high as 4,680 cases in the Dominican Republic and 3 cases reported in Anguilla. So far, we've reported 346 deaths within the Caribbean countries. Now, one would say, what facilitated this rapid spread of COVID-19 across the globe? And in doing so, you need to, and this is where we really get to know ourselves, and know ourselves not only as individuals, but as I said, as country, as governments, as a health system. There are several factors that facilitated COVID-19 spread across the globe. We talked already about the virus factor, meaning the pathogenicity as well as the transmissibility of the virus itself, how strong the virus is. There are other factors such as host factors, social factors, environmental factors, factors of trade and travel and transport. And we know that travel and transport was a significant driver of the rapid spread of COVID-19 across the globe, not only in terms of the rate of spread, but also in terms of the magnitude of the spread. Because as we know that with airports, seaports, with cruise ships, airlines, individuals came in droves from affected countries into countries where there were no cases of COVID-19. So trade and travel and transport were significant drivers of the infection, of the spread of the infection. But this is an issue that we cannot take lightly, because when it came to the banning or closure, travel restrictions and closure, what happened that it also impacted the logistics, the supply chain logistics of essential medicines, drugs, supplies, food into countries, particularly those countries that did not have the opportunity to stockpile on these very vital and important support. So there must be a balance, a strong balance between the impact that travel and transport has in importing cases into your country, as well as trying to ensure that your country have the necessary essential resources to sustain itself during the fight for COVID-19. There are also economic factors in health systems and preparedness resilience, which is crucial to whether or not COVID-19 will spread within your country, because a system that is not prepared is very weak and cannot respond to the virus. You will find that such systems will be vulnerable and facilitate the spread of COVID-19 within them. So in order for us to stop, suppress, or slow the spread of this virus, these factors must be addressed within countries within our region. Again, knowing yourself. This virus is new to us as humans, so we have no adaptive immune response. There are no preformed antibodies because the body never faced this virus before. So there are no preformed antibodies that are available to attack this virus. So we are vulnerable from that standpoint with no immunity. All persons are susceptible to infection with COVID-19. Don't care how young you are, don't care how strong you may appear to be, you're still susceptible to infection with COVID-19. What may differ is the degree of severity of the disease that you will get depending on your various status. We know that males, from studies from several countries, males were affected more often than females. We know that persons over the age of 60 years and persons with comorbidities such as diabetes, hypertension, heart disease, are vulnerable to developing severe forms of the disease and more prone to death. We know that persons who have suppressed immune system, and in such immune systems where the innate immune system that has the natural killer cells, as well as things like the cytokines, this part of the immune system is innate and is in your body, ready to attack any foreign entity that enters your body. The virus is no exception. But the issue here with the immune suppression as well is that the very same system that is there to protect you could also be the ones that can cause your demise, because I call them, these are suicidal cells, because the response is so overwhelming with what we call cytokine storm. They itself will cause severe disease and damage to your lungs, which resulted in the demise of many persons who ended up in our ICUs. In the Caribbean region, in particular, and also within the Black population, we have a high incidence of vitamin D deficiency. Vitamin D deficiency has been shown to be protective. I mean, vitamin D itself protects the immune system, helps and support and strengthen your immune system. So with vitamin D deficiencies being prevalent, it puts us at risk for more severe disease when infected with COVID-19 or any other viral illness. So that is another factor that you need to consider when considering your vulnerability to this virus. Knowing yourself also means that you must know your habits. You must know your habits, and you must know yourself, meaning knowing the social makeup of your country, whether or not there is overcrowding, whether or not there is extreme poverty, because these last two definitely increases the risk of spread of COVID-19 within the community. Human behavior, however, have a significant role to play in whether or not you contract COVID-19 and whether or not you spread COVID-19 to others. So things such as your cough etiquette, proper hand hygiene, environmental sanitation, these simple measures go a long way in not only killing the virus itself in instance of sanitation and hand hygiene, but also reducing the spread and transmission. We may have seen earlier in my initial slide on getting to know the enemy and knowing the virus, and I told you it's a simple viral particle surrounded by a lipid envelope. Soap in water, soap emulsifies fat. So lipid is fat, and simple washing of your hands will dissolve the covering of the virus and exposes its DNA, and the virus is killed. The same thing goes for substances such as alcohol, which is at least 60% and above alcohol, right? These methods goes to kill the virus. So you must know your behavior. You must also enforce those acceptable behaviors in terms of hand hygiene, and you must also know your enemy. In knowing yourself, you must recognize and at all times know your strength and your weaknesses, not only as individuals, but also as a health system, as a country. So central to whether or not a virus or disease will run rampant within your country will depend on how strong your health system is. Sitting at the center of a very strong health system is a strong leadership in governance within the health system. In looking at strong leadership in government, you must have the capacity within ministries of health to develop evidence-based health policies. You must have the capacity to develop regulations to regulate your health systems. You must have the capacity to develop very strong surveillance systems, as well as looking at and make sure you fortify your human resources for health, making sure you have enough doctors, nurses, laboratory technicians and technologists at hand, not only to conduct the regular function of your health system, but also to respond to surge capacity to events like the COVID pandemic. We need to make sure that we have the essential medicines and technology available, and medicines not only available during normal operation procedures from day to day, but also to be able to have essential supplies on hand or have the logistic supply chain in place that you can rapidly mobilize medicines and other supplies in events like these in a timely manner. Health technology is very important in looking at information systems for health to ensure that you have real-time data, not only real-time data from your local health, local community health clinics, sentinel sites, but also health data from overseas, using epidemic intelligence from what's happening in other countries. Because if you're not able to tell what's happening in other countries or parts of the world, then you would not know your risk at home in countries where we reside here in the Caribbean, be it Turks and Caicos or anywhere else. Obviously, health financing is very important in ensuring that we can have a strong health systems, because everything requires funding. Everything requires funding. The primary healthcare system is the solid foundation, the basis, the foundation of our healthcare system. And we must have a strong primary healthcare system if we want to combat conditions like COVID-19. Social participation and intersectoral collaboration is essential, meaning that we must involve individuals outside of the health sector at all times, and not only in times like COVID-19 pandemic, but also as part of our regular work in helping to shape and develop health policies. They must be a part of the solution to the problems that we have. So intersectoral collaboration, social participation, collaborating with non-government organizations, collaborating with the private sector is essential and crucial, not only as part of our regular function, but vital in response to events like this pandemic. The international health regulations was put forward by the World Health Organization in 2005, international health regulations have several provisions. One of the provisions require countries to have reporting of notifiable diseases or diseases that are designated fake or public health emergency of international concern to the World Health Organization. It also calls for the strengthening of our port health systems, meaning we must ensure that our airports and seaports have the surveillance of persons entering and leaving our countries to detect in an early manner any disease or any threat to our health, our national security, our national health security within our countries. So we will go through those issues in more detail as we go on. Now, so within the Caribbean region, having that in hand, several countries, all of the countries in the Caribbean region have been over the past years, have been working collaboratively with WHO, with PAHO, with other organizations such as CARPHA, University of the West Indies, and other supranational entities to strengthen their health system. And so, so we can say that there are a number of good that came out of those strengthening, because it enables our countries within our region to respond in various manners to the attack of COVID-19. We found that there are several methods of response and attack that countries implemented during this period. It called for the activation of the emergency plans of countries. Now, most countries would have gone through, or all countries would have gone through the H1N1 pandemic. Countries would have gone through the SARS epidemic. Countries would have gone through the Ebola scare. Countries would have prepared at various times. And so each one of these exposures should have strengthened the health system of their countries and also learned from those experiences. One of the good that came out of the H1N1 as well as the SARS pandemic is the development of the various preparedness and response plans. Granted that a lot of countries within our region did not get to activate those plans or fully respond in those plans as they should have, but those plans being available facilitated the rapid development, amendment of those plans for countries to then respond to this COVID pandemic. These plans, however, must work hand in hand with national plans. Most countries would have what we call a National Health Disaster Coordination Mechanism or unit. National Health Disaster Coordination Mechanism or unit works hand in hand with the national disaster offices. And the response is escalated depending on the phase of the threat that the countries are experiencing for that time. We found that a number of countries within our Caribbean region, the majority of them have either a preparedness and response plan based on the pandemic influenza plan, or they would have had developed from scratch the new preparedness plan specific for COVID-19 pandemic. These countries, what we found that had those plans, had a better, well-organized and coordinated mechanism, particularly those that had the mechanism where it activated and elevated to the national level, to the National Disaster Office, but still facilitating proper coordination and collaboration at all levels of care within the health system. We found that countries also establish event-based surveillance systems. Now, during regular times, during normal operations, every country have what we call a syndromic or indicator-based surveillance. And this is where all sentinel sites or health centers are supposed to report the presence of certain illnesses within the community, such as severe acute respiratory infections or influenza-like illnesses. These are reported on a weekly basis to the central government, the ministries of health. And any changes in these reports or any suggestion of outbreaks will then enable the activation of certain outbreak investigations. But in this case, for this COVID-19 pandemic, in addition to that normal regular surveillance system, we then have the establishment of an event-based surveillance system. And this event-based surveillance system is then based on looking for disease based on a specific case definition of the disease. We saw within countries in the region the enhancement of port health surveillance. The port health surveillance range from persons implementing measures such as forms that need to be completed on the plane or at the port of entry, persons using surveillance gear such as temperature monitoring, persons actually using the advanced passenger system or the APIS system to look for persons of interest coming in on flights into countries, and then using that to have targeted approach to persons entering their countries. And then we have countries that had very advanced and sophisticated temperature monitoring system within the arrived immigration halls, where you did not need to put a temperature gun to their foreheads, but everyone standing in line, their temperatures were being monitored remotely within the health port health offices. And so this is very robust. There's a variety of methods that were implemented within the Caribbean region with regards to port health. The port health with regards to cruise ports, the same thing applies because the cruise ports turned out to be one of the biggest threats to the importation of viruses of COVID-19 into the various countries. And port health was stepped up in terms of the surveillance that took place, having cruise ships even comply even more strongly to the Maritime Declaration of Health that are required by ministries of health in the various countries. Public education and communication campaign is essential. In the majority of countries in the region, establish public health education and communication campaign as part of the risk communication. A number of countries implemented, just about all of them, with few exceptions, implemented travel restrictions. Well, all of them implemented travel restrictions, but all of them with a few exceptions, implemented travel bans. So there were airport closures and port closures. We need to ensure, however, that we have the resources to fight if we are going to plan an attack against COVID-19. So in doing so, there needed to be an estimation of the potential impact of COVID-19 on our countries. How many cases are expected, whether or not we establishing testing capacities within countries, whether or not we're establishing quarantine and isolation and treatment facilities in our countries, enhancing the treatment capacity, such as having ventilators, essential drugs and equipment, increasing the stockpile of drugs and equipment within our countries, and identification of cases, isolation and treatment of these cases, the quarantining of contacts, and the social distancing and curfew that are required. We went through this already, but we cannot overemphasize the need for effective command and control within the organization of and coordination of the response in it. We needed to have these established at the national disaster level with well-coordinated and effective communication at the national level, the ministries, the health centers, the hospitals, as well as the private sector clinics that form the basis of the primary healthcare services delivery, and frequent communication with the public. Risk communication and engagement and community engagement is essential. What we find that during this pandemic, there are lots of fake news. There are lots of rumors. We need to be able to reduce the infodemics. There's an abundance of information that came with COVID-19 from many sources, and persons did not know which information to deem as truthful. So ministries need to establish a communication and risk communication and mechanism in engagement with the public, so that you can build trust, so that you can dispel rumors and fake news that undermines the response and further facilitate spread of the disease. You need to have effective public health education and engagement and campaign that will change persons' behavior. And you need also to address the fears of the people and the concerns to lessen the psychological impact. Because if there's one thing that this pandemic shows you, that fear in certain instances was almost greater, the impact of fear on individuals was almost greater than the impact of the virus itself in most instances. So much that having mental health and psychosocial support is an effective, is an integral component of the response to persons with, not only persons impacted, those on the front line, such as very important healthcare workers, as well as other persons on the other persons on the front line, as well as the public at large. Those persons will need that level of support in order for them to function. We need to take note of the supply chain logistics. Yes, we need to make sure that there's a stockpiling of essential medicines and supplies. There are lots of countries, there are several countries who had on hand personal protective equipment from previous pandemic, like the SARS and the Ebola, particularly the Ebola, which is the most recent one, still have those supplies on hand. And fortunately, they were able to use them to start response to this pandemic. But those were in short supply. And because of supply and demand, we find ourselves in the region competing with other countries. And so economies of scale or lack thereof and inability to have bulk procurement reduce the opportunities for countries within our region to procure those things directly as countries. So you had organizations such as the Pan-American Health Organizations who will assist countries through the bulk procurement mechanism to get access to those vital supplies, such as personal protective equipment, laboratory testing equipment and supplies, ventilators and other medical supplies. But then again, within the region, we saw, we were happy to see the cooperation and sharing of resources between countries within our Caribbean region. And this was exhibited most recently by cooperation between Cayman and a few other CARICOM countries. So it is important that we can have that level of camaraderie and cooperation in these times of strife, when persons may be inclined to be more selfish with what they have for the benefit of their own population. But if you have the access, you need to share it. In dealing with COVID-19, the surveillance, establishing a very robust surveillance system is essential. We need to know the case definition of what's a suspected case, or what's a confirmed case. You know, suspected case being someone who would have either had exposure to the virus, meaning that they would have come in contact with someone who was confirmed to having the virus, or have traveled to a country where there's community transmission of the virus. But in addition to that, have symptoms of severe respiratory infections, as well as other symptoms that I mentioned earlier of COVID-19. And then the confirmed case are persons who are confirmed by laboratory testing of sample using the established and approved methodology to have had COVID-19. And these are the confirmed cases. So, so we need to continue to use our existing severe, what we call the SARI, the severe acute respiratory infections and influenza-like illness surveillance platforms that countries already have and work well throughout the years. But we need to establish a robust event-based surveillance system. In addition to that, which most important, to have contact tracings of every person who are exposed to persons who are confirmed with COVID-19 and quarantine them for the 14-day period of incubation, or what was established as the incubation period. Now, testing strategies, this is another area where there are lots of concerns and confusion within countries, and rightly so, because everyone is concerned as to whether or not they have COVID-19 or whether or not they're at risk. But what is important is that we must know who, when, and with what to test, and for what purpose are we testing individuals. And we must recognize that testing within the context of a public health emergency of international concern, such as COVID-19, testing for the disease rests with, or is a mandate of, the ministries of health of the individual countries. The ministries of health then can work in collaboration and in partnership with the private sector. So the ministries of health set the standards. The ministries of health validate which tests are approved, which tests are valid to be used within countries, and for what purpose they are to be used. And this is an important command and control mechanism that the Ministry of Health have as its responsibility, and it must exercise it at all times. So in prioritizing the testing of individuals, we must look at the suspected cases. All countries have part of their testing protocol suspected cases of persons who meet the case definition of a suspected case will be tested. Persons who are hospitalized, maybe probable cases, they must be tested and retested. Healthcare workers who are at risk, or after going through their healthcare worker risk assessment and may have been found to be at high risk of exposure, those persons are also prioritized to be tested. Then we get into the category of testing asymptomatic persons. Persons who are asymptomatic may be persons who are in quarantine, who are just exposed and may or may not have the disease, but you're waiting and watching to see whether or not they develop signs and symptoms of the disease. Or you may want to test persons at risk, like such as elderly in nursing homes. And then if you have the resources at your disposal, you can look at whether or not you want to test the general public. Now, there are two types of testing, two main types, but three types, but actually I will discuss two, which is the molecular or the PCR, what you call the preliminary chain reaction type testing, or the rapid antibody test. Then we need to discuss whether or not we're using these tests for diagnostic reasons to decide whether or not you have the disease, or whether or not we're using it as part of a surveillance of immunity within the community, which we call seroprevalence of the disease within the community. So looking at the molecular or PCR testing, which is the test that most countries in the Caribbean region now have, there are a few countries who have not yet acquired this machine, and simply because of the supply chain logistics and it being very difficult to procure if you are not ahead of time. And so it makes it difficult for you to procure. In Turks and Caicos, we know recently that it was announced that you recently got your PCR machine to do in-country testing of COVID-19 using PCR. But before that, all countries had access to other testing modalities or platforms such as CAFA, which is the reference laboratory. So in doing PCR-based testing, the samples are collected, usually a nasopharyngeal swab, up the nose. It is then transported under conditions that are ideal to maintain what we call the cold chain. So this test, yes, is subject to false negatives, and false negatives do exist. But most times when they exist, it means that either one, you did the testing very early after the infection. You did not give the virus time to establish and multiply within the body and to be shedding its load in the body. And so the test will give you a false negative test. Or the sample may have been contaminated, or you may have had a break in the cold chain of the transport specimen, or you may have had a prolonged transport of the sample with degradation of the sample before it reached the laboratory. However, this test is used to confirm the diagnosis of persons with COVID-19. It is also used in some cases to confirm the diagnosis in persons found to be positive using the rapid antibody test, which we'll go on to at this time. The rapid antibody test is a subject of much discussion. The PAHO, WHO have just recently, I think up until 2 days ago, produced a protocol and guidelines, and to give countries some guidelines as to how they can go about utilizing rapid antibody tests. But what we know is that there is no rapid antibody test to date that has been approved by WHO for use for diagnostic purposes, for diagnosing whether or not you have COVID-19 infection. And the reason why this is the case is because there's a high rate of false negative, meaning that the test tells you that you're negative for the infection, but you did indeed have the infection or have. Now, this test for antibodies, and there are two types of antibodies that may appear. One is what we call the IgM antibodies, and these antibodies appear like about a week after persons develop symptoms, and it's very short-lived. And so it tells you whether or not the infection was there recently or whether or not it's a person who is recovering from infection. It very really diagnosed person, or very really tells you that you have an active ongoing infection. Then you have the IgG antibodies, and these antibodies only appear 2 to 3 weeks after persons would have recovered from the infection. And so it could only tell you that you had an infection, but not that your infection is active. But these antibodies stays in the bodies for a long time, lifelong, and it's supposed to provide immunity under normal circumstances and protect you from getting a second infection. But recent studies have been shown, and there are some cases where persons actually, there are reports of persons getting a second infection. And so there's much yet to be learned from this virus in terms of its ability to reinfect individuals. There's a current, as I said, this particular type of test is used more to screen individuals to see whether or not they have had infection in the past with COVID-19. And it is used to do surveillance of the level of immunity within the community. So it means that if I was tested positive for this particular, using this particular method, it means that if I had a past infection, and it means that I may be immune, and hence if I go out as per usual, the risk of me getting reinfected is very low. And so this kind of test of the population using this method facilitates the mobilization and getting people back to work, meaning that they can be exposed because now they're protected. However, in situations where you use this test and the test comes out positive, particularly if you're positive for the IgM antibodies, which shows up earlier in the body during recovering persons, you may want to confirm this particular test via PCR to make sure that the person still does not have an active infection. Because if they do have this active infection, then they need to be managed accordingly, appropriately, to do diverse contact tracing, isolation, and treatment of these individuals. So this kind of testing is done on a national level. It must be done in collaboration with the Ministry of Health. And actually, some ministries of health are using this as a screening method at populations at risk, or using a particular sample of the population. And then what they will do, they will then go and test with PCR for those ones who are positive to see whether or not these individuals are indeed positive for active disease. What needs to be communicated, however, is that persons taking this test must know that this test is not for diagnosis. It's not telling you if you're negative. It does not mean that you do not have or cannot have the infection, because there can be false negative rate, as we told you before. And so it gives you a false sense of security. And this must be clearly communicated with individuals within our population. In looking at the clinical management, which is important in the management of patients, you must have, early on, the management is very supportive. Persons who need oxygenation, because in the majority of individuals, they are very short of breath with low oxygen levels, and they need oxygen support. IV fluid therapy as well will be implemented, but these must be used conservatively, because the lungs itself is already kind of drowning in fluid, and you don't want to fluid overload these individuals. To date, there have been no particular antiviral medication that have been approved for the treatment of COVID. There are a number of studies that have shown where some medications like hydroxychloroquine, chloroquine, with or without azathioprine, or medications such as remdesivir, lopinavir, as well as interferon, have been shown some promise and shown recovery. But these are small studies. So we don't know that whether or not the improvement in these patients is by chance, or whether or not it is by the actions of the drugs. So it really requires more randomized, prospective, double-blind, controlled studies, large studies to look at the benefit and the effect of these drugs on the disease itself. The WHO is currently putting on what we call the Solidarity Trial using these most 4 promising drugs. And a lot of countries within our Caribbean region are actually joining this trial to see, while getting to use the drugs, to see whether or not is useful and to contribute to the world literature of it. And this is being done in collaboration with WHO, PAHO, UWI, and CAFA. However, the public health measures in terms of fighting this disease, we must be able to contain it and suppress it. The containment and suppression strategies, the core of it rests within the identification, testing for persons who are suspected of having COVID, isolating them if they're tested positive, treating them, doing the contact tracing of individuals who were exposed to those individuals, and then repeating this whole cycle until you are able to contain and suppress COVID-19 within your population. The challenge for us initially was identifying the first case. Countries were waiting with bated breath trying to identify the first case of COVID-19. Then we got to a situation where, yes, you got the first case, you're able to do contact tracing, identify every case that linked to the index case, and you had sporadic cases popping up. Then we had clusters of cases where all of them are linked to a particular case. And in some countries now have gone to the stage where they have developed sustained community transmission. Now, once you get to the stage of sustained community transmission, you need to get into more mitigation measures, such as social distancing, closure of places of mass gathering, like schools and airports, etc., and ensuring that you can have the opportunity to go through your process of identification, testing, isolation, treatment, and quarantine as part of your strategy to suppress the virus, as well as to suppress, or what we call flatten the curve, to enable the health system to catch its breath and respond more appropriately to the virus. This suppression and containment also ensure that you adhere to personal hygiene and workplace sanitation measures to ensure that you get into the whole issue of healthcare workers using their personal protective equipment effectively. Now, when it comes to the wearing of masks in public, there's a whole issue of wearing of masks in public. But all I will say on that subject is that there has been no major studies that have shown the benefit of wearing masks in public. That does not mean that there is no benefit, because we know that when you wear a mask, the mask protects the other person more so than it protects you. But each person protects each other. And so there are guidelines that WHO has put out on the wearing of masks in public. But most important, what is important about wearing of masks in public is that individuals need to know how to put on the mask, how to take it off, and how to care for the mask, because you will run the risk of infecting yourself if you do not do those things properly. So a public education campaign has to go hand in hand with a policy that you put in place for the public use in wearing of masks. And this is what I'm talking about, flattening of the curve, where you need to have, in order to flatten the curve, you need to know where the curve is. So it means that you would have from the onset done your model to do projections from the very first case or cases to see where the trajectory is going to go. How many cases I expected to get without intervention, without any kind of measures. And then by putting in place those public health containment measures that I just spoke of, if they're effective, then you can lower the curve to that blue level to give the health system the chance to respond and to cope and to contain the virus until you are able to not eradicate, but to suppress and contain and to slow the progression of the epidemic. We all know that there are many issues. The COVID-19 have a major socioeconomic impact. All of our countries in the region are heavily tourism and service-based economies. There were restrictions on trade and travel. There were curfews, enforced physical distancing, closure of businesses, reduction of exports, provision of stimulus package by government in the face of declining revenues into government. Negative economic growth will incur, particularly after 2 quarters of negative economic growth. We will be pushed into a recession. So there have been predictions of a recession. And if it continues throughout the year, predictions going into depression. So there are many job losses, major impact on social welfare system. So there's a great need for proper financial planning, prudent fiscal management, and there's a need for us to be more innovative in the way we do business. We cannot do business as usual after this COVID pandemic. We need to know how we can be more successful as a country going forward. But how do we open up our economy? How do we go about relaxing and adjusting the public health measures in order for us to open up our economy? What we must realize though, we have to be careful how we erode the gains that we would have gotten over the past few weeks and months in dealing with COVID. The lives that were lost in the fight against COVID. We need to be careful that we don't open too suddenly, too quickly, and open up ourselves for a second epidemic and a third epidemic and recurrent epidemics within our society, and even impacting our economies even more. So we need to ensure that that COVID-19 transmission is controlled, is suppressed and controlled by the measures I spoke to earlier. We need to ensure that we have sufficient public health workforce and health services capacities in place, either starting from now and going forward into the future. We need to ensure that the outbreak risk in high vulnerability settings, such as hospitals where healthcare workers or nursing homes, are minimized. We need to ensure that we have preventative measures in place within workplace, whether or not to ensure that your employees, if they're sick, they go home and they stay home. If your children are sick in the schools, they go home and they stay home and report it to the ministries through our surveillance system. We need to ensure that we can manage the risk of exporting and importing cases from our communities where there's high risk of transmission. So our surveillance system and our port health system have to be strengthened. We need to be able to have the epidemic intelligence looking at what's happening in other countries to assess the risk of other countries and the risk of importing disease into our country before we fully open up our borders. These must be assessed. We need the communities need to be fully engaged, educated, and empowered to adjust to the new norms, because there are lots of changes that's going to take place. There's going to be major paradigm shifts, and we as a people within our Caribbean region have to be ready for that paradigm shift. So we as a government need to ensure that we empower and educate our people for this shift. So in preparing for the future, life would not be the same. There may be new ways of doing things. There needs to be a greater focus on the strengthening of our health system and the development of a robust surveillance network. We need to ensure that we can stockpile on our supplies so that we wouldn't put ourselves in a position where we have to compete with larger countries and not having the buying power and the purchasing power to compete for those supplies. We need to ensure that we have a diversified economy, that we don't just base our economies on tourism and service-based economies, that we could withstand the economic shocks, that we could be more resilient as countries within the Caribbean region. And we need to recognize, however, that the health of the nation is indeed the wealth of the nation. It took COVID-19 for many countries to recognize that one little virus could bring nations and countries in the world to its knees. So we must recognize going forward, we need to invest in our healthcare system, in our healthcare system strengthening, and in our people. So I thank you, and I now, if there's time for questions, I'd like to open the floor for any questions that you may have. Thank you.
Wow, thank you so much, Dr. Ewing. This presentation was certainly chock full of information, and although we have scheduled this until 4, just about everyone is still hanging on to every word you're saying. So we're gonna go ahead and delve into some of these questions that have been submitted. Some of these may touch on things that you've mentioned, but we wanna make sure that we want
That's good.
Okay, how long does the virus stay in asymptomatic individuals, especially if they've never manifested any symptoms and they hence don't qualify for testing?
Okay, one sec. I'm trying to switch. Am I on camera? I'm trying to switch.
You're on camera. You're both on camera and we're seeing the presentation.
Oh, okay. All right. All right, trying to exit the presentation. All right, so the incubation, once a person is infected, the incubation period is about, as I said, 2 to 14 days before the person experiences symptoms. After that, the virus will stay in the person's body about a total of 14 to 21 days. So what you'll find is that individuals, after a period of about 21 days of being diagnosed with the virus, then you could then engage them with a period of testing to see whether or not they have cleared themselves of the virus. Because testing at day 21, and the virus is absent, it then means that you have recovered from the virus. All right? That means that the virus itself is no longer present within the body.
Okay. Now, if that is in fact the case, and you've already mentioned that there are some reports of reinfections, can you share with us, in terms of those reports, what are we looking at? Can you clearly say that there is a ratio of reinfection that can be identified at this point?
Not as yet. Those reports are more anecdotal, sporadic reports, and we need to. So those reports are significant from the standpoint of whether or not the level of immunity that someone acquire, meaning that okay, you're exposed to the virus, and your body starts to produce antibodies in response to the virus, like IgM and IgG antibodies, particularly IgG antibodies. And that is supposed to offer you immune protection to protect you from. But if that is not produced in sufficient quantities, or the virus has changed to some extent, then you can find that you can probably get a reinfection with the virus. So there are a number of things that need to be looked at to determine whether or not this is something that we can say is a given, that yes, persons who are infected are at high risk of reinfection, or whether or not there's a very low, and these are just anecdotal, incidental cases.
Mm-hmm.
Right?
Back to those asymptomatic individuals.
But what I would say, that is one of the importance, however, of doing what we call seroprevalence, meaning testing for persons within the community for the antibodies and to see whether or not they have past infections. Because if you don't test that person to see whether or not they have past infection, then when they come up with an infection, you don't know whether or not that is a new infection or a past infection. What it may tell you, what you may see that can tell you that if they end up showing at the time when they're tested positive, whether or not they have a high levels of IgG antibodies in the very initial, within the first few days of that person being tested.
Thank you for elaborating on that for us. For asymptomatic individuals who've tested positive, they've gone through the quarantine period. If they come out of that advised period and they test positive again, is there a longer time for quarantine at that time, or do we stay within the same 14 to 21 day framework?
Well, just to note that persons who in quarantine are not necessarily persons who are positive. If you persons who are in quarantine are persons who are exposed, meaning that if I have the virus and I have confirmed and diagnosed with COVID, and you come in contact with me, then just because you're exposed to me, then you'll be placed in quarantine. But it does not mean that your exposure to me led to you getting infected. So the quarantine period is a waiting period to observe you to determine whether or not you develop symptoms and signs of the disease that will tell you, yes, okay, you were exposed and you were infected. So persons who are in quarantine are not infected persons. Actually, persons who are in quarantine, if you develop symptoms or you're tested and and you're positive, then you're moved from quarantine into isolation.
Okay, thank you for that. Also, with respect to talks of vaccines, we know that there's still a lot of unknowns, but in what you've seen and the developments that you're learning about, are you able to speak to how close or far away we are from seeing a vaccine?
No, I know, all we know that there's several vaccines in trial. I know there are about 6 vaccines that are well advanced in trial ahead. But even that in itself does not mean that they are even ready for testing and human testing. And so I think we are still some ways out before we actually have an effective vaccine that we can use and feel confident in using in individuals.
Okay, thank you. Another question that we have here, assuming COVID-19 is contained or eradicated in Turks and Caicos, from a medical viewpoint, how do you see the reopening being staged? Firstly, locally, and secondly, for incoming tourism. And also, there was another question with respect to what protocol may need to look like for flights and incoming traffic.
Yeah, I would almost reserve that for the government. But what I will tell you is that what I spoke to earlier is that there are certain measures that I just mentioned, and those are public health measures that we must focus on heavily and preserve. So I would say that if you decide that you're going to open up your borders, having resumption of flights, then you need to know where individuals are coming from. You need to know the state of affairs in the country where individuals will be coming from in terms of the stage of the outbreak, whether or not you have still ongoing active infections and outbreaks. It'll be good to know what the seroprevalence of individuals are in those countries, whether or not they have a high seroprevalence, meaning they were already all exposed to the disease, and they have a high level of immunity to the disease, and hence they're less likely to probably be bringing anything to your shore or catching something while they're here and fostering an outbreak. You also need to be able to enhance your port health surveillance. In most countries, I was very impressed with at least 2 or 3 within the Caribbean region in terms of the facilities that they have for port health surveillance. Others are not as well established, and all they have is a health desk with 1 nurse probably there waiting, which is not enough, which is not sufficient, because there's no epidemic intelligence that goes with it. Just wait for a person to come off flight. We have advanced passenger notification systems that we can use in port health. We have the Maritime Declaration of Health, which is an advanced passenger notification system for the cruise lines. So we need to be able to use those systems, improve them, ensure that they're working, and feel confident that we can let persons in before they come to the Turks and Caicos or in the countries in the Caribbean region. What I can see happening in the future is that airlines themselves, like what happened with 911, in addition to establishing the metal detectors and the bomb detectors and all those other detectors, will establish the temperature detectors when you're going through. So exit screening, meaning before you board a flight, you need to show that you're temperature free, right? So there are lots of things that will happen in the future, but we need to ensure that the basics, we need to protect ourselves, our borders, before we fully open up to the economy in terms of travel, etc. The same thing goes with schools and social distancing. And I think the method of social distancing is a good thing. And we need to really see how long we can continue that in a phased approach before we fully, and I think this can be facilitated with us doing the seroprevalence studies, the rapid antibody test studies in collaboration with the Ministry of Health to determine who can then move, who can go to school, who can go back to work. Those are the things that we need to establish very quickly.
Great, thank you for that response. There's a question here with respect to testing, and I'm sure that you've probably had this question posed many times. Rather than waiting to see if persons show symptoms, why not test persons who are in quarantine so that you'd know immediately?
Yes, there are some countries in the region who have been testing persons, in addition to testing persons who are symptomatic, because they had the resources. Well, they think they have the resources, because there are some countries who run out of the resources, like the viral transport media and swab. They run out of them. but because they have access to more, they will get them. But in quarantine, persons are asymptomatic. You know they were exposed. Yes, you can test them, and there are countries who have been testing persons who are asymptomatic. The yield in terms of positive is very low in most instances. Very few persons were tested positive. But it doesn't mean that you can't test them. But the question is, however, whether or not they are truly, if they test negative, whether or not they are truly negative. Because as I mentioned earlier, even using PCR-based testing, depending on when you're testing the person, will determine whether or not that person will show up to be positive or not. Because if you test them very early during the exposures, let's say I have COVID-19, you exposed to me, I put you in quarantine in day 1 or day 2. After your exposure to me, they come and they put you in quarantine, they test you on day 1. You most likely, you stand a likely chance that you would be negative. Even though you may have had the virus, get infected, but incubated. Now, if we go and test you later on, maybe on day 7 or 8, when most persons are likely to develop symptoms on average, then that person may then have a chance of being positive if they indeed have the virus. But even in those situations, even when they're tested negative, those persons in most instances are either one, kept into quarantine, particularly if you are not an essential worker or otherwise, you're kept into quarantine or asked to self-quarantine for the remainder of the 14 days.
Okay, great. We just have about 3 more questions, if you can bear with us.
No, I can bear, I have the time.
Wonderful, thank you. Let's touch on the masks. Are surgical N95 or KN95 masks effective in stopping the inhalation of the virus?
All right, both N95 mask and its other derivative, which are respirator masks, and these are either American standard, which is the N95 is the American standard, the European standard is the FFP mask, and the KN95 is the Chinese standards. Either one of those are highly certified to filter the majority up to 95 or plus percentage of viral particles. And these particular masks are more effective or designated to be used in situations where there's a high risk of exposure. In particular settings where we call aerosol generating settings. When we talk about aerosol generating, meaning that if you have to put someone on a ventilator, and because of the breathing of the gases directly from the lungs into the anesthetist or intensivist face, in very small, fine mist-like particles, aerosolized particles, those persons stand a higher chance of being infected if they don't have that type of mask available. Now, if you used to wear the regular surgical mask in that kind of setting, then you are high, the risk of you getting infected is greater because the surgical mask, the pores are larger, the virus particles are smaller, and so the filtration is less, and you stand a higher chance of getting infected. So that's why we are promoting that those types of masks, the N95 and the surgical mask, be reserved for persons in the healthcare settings because those are the ones who need it most, those are the ones who will be exposed most, and particularly in this kind of time when they're in short supply, then what you don't want to do is that they are consumed and the healthcare workers who are important to us have none. So, you know, at this time, I know it would be remiss of me, but I would like to give a big shout out to all of our healthcare workers, our frontline workers, those persons who are on the front line, be it in healthcare, be it on immigration, surveillance, customs, etc., because they put themselves directly in harm's way every day to save lives, right? And that is the important thing that we must recognize for them. So if we want to help them, try not to misuse those type of masks that can be made available to them so that they can stay alive to save your life.
Great, thank you for that. We certainly echo your sentiment with respect to saluting our frontline and essential workers. Is there a different strain here and there of this COVID-19? Has the virus mutated in any way?
Yeah, there's no evidence thus far that there is any major mutation that is going on. We know that when you look at the disease profile in Italy compared to what happened in the U.S. or other parts of Europe, we find that there's a higher mortality rate among persons in Italy. And this may be explained because of the age profile and the disease profile that currently exists in Italy, maybe a higher proportion of elderly persons with comorbidities, etc. But there's been no evidence thus far to show any a major mutation of the virus that could account for any difference in behavior for things like the different virulence experienced in different countries, or the ability to reinfect individuals that we have seen on the one odd cases. So no.
Okay. What are the current survival rates for patients put on ventilators, and are there any long-term health effects as a result?
We know that I would have to look at the specific stats for persons. I have to separate those persons being admitted versus being put on ventilators. Now, when persons have to go on ventilators, the chance of survival we found to be very low, simply because of the what we call the cytokine storm that goes with it, and the diminishing return that you get with ventilation, and so much so that clinicians now are wondering whether or not they should be putting persons on ventilators. And so the protocols a lot of people are developing now is to, for as long as possible, try to keep persons off ventilators and only put them on ventilators when it's really dire strait and cannot help it or avoid putting them on ventilators. So there are many schools of thought, there are many experiences that are being shared. Right now, we've had countries have been recently the benefit of sharing of information from clinicians from China, Italy, Spain, sharing their experiences with persons here in the Caribbean region. And we are about to also have a here in Paho, in our office here, to have a sharing among our country offices of clinical experiences in managing these patients who are admitted, and what they found work or did not work, and to have best practices established that persons can really learn from each other's experience, and that's what we want to do. But yeah.
All right, great. We're going to get 2 more questions in, and then you guys, thank you so much for sticking and staying with us. But we do have a webinar that starts at 5. And of course, we want to let Dr. Ewing get back to the good work that he's doing. So there's a question with respect to the fact that so many governments seem to have taken different approaches on the lockdown period, what should be done in terms of curfews, social distancing rules, and the like. And so this individual is asking if there's any agency that has done any modeling on the region, or even on TCI in particular, on a best case scenario for dealing with COVID-19 in the region.
Well, I think you're preempting, because for us in the region right now, I think we are on the upside of the slope. We haven't reached the top of the curve of the curve as yet. I think it's too early to tell whether or not the measures that were put in place, and some of them very early measures, were indeed effective, meaning that they helped to flatten the curve. So persons are looking at the region and say, hey, the number of cases so far are low compared to what was projected or envisioned. But we don't know. We don't know whether or not this is just the beginning and we are on the upside of the curve or not. So there's still some waiting time to happen. Some of the things that we need to look at is when we look at containment. If you have effectively contained or suppressed the virus, if you look at your cases, the number of new cases popping up, if you have not had a new case within 2 incubation cycles, that is 28-day period, within a 28-day period, if you have not a new case, then you and your surveillance system looking for suspected cases are indeed robust, then you can almost confidently say that, hey, you have managed to suppress and contain the disease. All right. There's one country that we're looking at now that may be in that position, but they're a few days off for that time period in terms of the 2 incubation cycles. So that's a good model to go by. But the strategies, countries adopted the different measures because they know their system, they know themselves. And if you know that you cannot afford to deal with the number of cases that would come with not doing anything, and that you would be overwhelmed and you would have unnecessary or unavoidable death, then yes, taking measures early, which some countries elected to do, may be the best thing for you. And you balance that with how does it impact my economy? So it only takes national governments to make those decisions based on what's happening in their individual countries, based on the economy, based on their finances, based on the strength of their health system, based on their reserve capacity. They know themselves and they know what reserve they have to fight. And so the measures that they took depended on that. Some countries say, hey, look here, the revenue that I am getting does not justify, the little revenue that I'm getting does not justify me keeping my borders open for the significant impact that I will have that I know that I cannot handle. And so they close their doors early, very early, right? So, but we would not know those things until we are on the downside of this curve. Like we can now learn from countries in Europe. We can learn from China, who is on the downside and going to containment. We can learn from Italy. We can learn from Spain, how they how they're reopening the economy. But for now in the Caribbean region, we have some lessons to learn after we find ourselves on the flatten the curve and on the downside of the epidemic curve.
Thank you so much. And we'll end with this particular question. This one's so important for community. We've seen a lot of people get into the mask making business now, and people are resulting to making homemade cloth masks for themselves. Are these helpful? And with mask wearing in general, should masks be reused? Well,
fortunately, the cloth masks that people are making now, they actually, I'm sure they can be easily washed with your chlorine, bleach, and soap. And so that will effectively kill any virus that exists. So yes, you can reuse them. When you make your mask, you may want to make your mask, because what I can foresee happening later in the future is that, you know, the filters that exist within the regular surgical mask and the N95 mask, I can see those filters being developed as standalone items, not in a mask form. And so if you design your mask that you can have an inner pocket and you can easily slide a filter in that increases the protection and filtration of the mask, it may even be something that you can do. You need to know, however, that when you wear a mask and you go to a person, you come within that physical distancing space in less than 3 feet or less than 6 feet, right? And someone coughs. What happens is that cough, those particles are deposited right on the face of your mask, okay? It may not necessarily, some may go through, some may not go through, or the amount that goes through, the dose that goes through may not be enough to infect you, right? But they're on the outside of the mask. If you don't know how to take that mask off, meaning that you're always dragging the mask and putting it under your chin, you're dragging it and it's touching your mouth, the outside of the mask touching your mouth when you bring it down over your face to talk, or you take your hands and you rub the outside of the mask and take the same viral particles you then take and you put in your mouth, your eyes, or your nose, right? You increase your chances of getting infected if you do not know how to wear, use, and put on and take off your mask properly. So some major public education needs to go into developing a policy that says there should be public use of masks. And if you decide to make a policy that there's public use of masks, then herein lies an opportunity to study whether or not mask is helpful or not. Because there's no studies that have been done to show whether or not mask is helpful in these kind of settings. But this will then have the opportunity to give the evidence so that for the next event, we could then say that, hey, you know, during COVID-19, it shows that mask was X amount percentage effective in doing it. So those are the opportunities, and those are the comments that I'll have on the wearing of masks now.
Thank you so much. And because we've talked about masks, I'm just going to ask you to oblige me for one more question. Surface contact. That has been something that we've heard more about recently. We've been advised to take extra precautions when we go and pick up items from the food store and wherever else, bringing them into our homes, wiping them all down. What is the new information with respect to this virus and how long it stays on surfaces?
As we say, the virus will stay on surface depending, the length depends on the surface. The length of time it survives on the surface also depends on the ambient condition, the temperature and everything else that goes with it, the humidity, those things that goes with it. And so it varies. We know that it lasts longer on the surface than it was originally thought when the virus first appeared. But I'm not sure that we should really, as individuals, as public citizens, be trying to decide whether or not it lasts longer on this orange than it does on the apple, than it does on the tin of sardine. What's important for us, and which is a good practice to get into, yes, your items, when you bring them home, you write them down. Because we don't know the dose of the virus that was deposited by someone's hands, handling those things when they're stocking the shelves. We don't know whether or not it was just placed, whether or not that shelf was stocked 5 days ago or 2 minutes ago before we pick it up. So we don't know. So how long the virus lasts doesn't matter in those situations, because we don't know the circumstances on when a virus may have been deposited on that item. All right. So what's important for us is to practice proper adequate sanitation and wiping down surfaces, items, food stuff, washing vegetables, wiping down cans and wiping down and washing your various fruits, as well as sanitizing the top. Doing those same practices as tracking into the house with your shoes. Those are good habits that we need to get into. And that's the new norm that we're talking about. And most of all, get into the habit of washing your hands with soap and water and sanitizing it as often as possible when you know particularly that you may have been handling out in public, holding handrails, handling stuff, opening doorknobs, etc.